I'm working as an assistant professor in ENT about carcinoma of the larynx. And just to start with, because this is a one-sided lecture, and automatically we won't be getting any feedback from any of the students. So I would like to give you a case scenario about CA larynx, and probably you'll be seeing a case presentation on your screens as well. And this is the best way to have a one-sided interaction is to see a case scenario, see what relevant investigations can be done to cope that scenario and automatically then understand something about the disease. So on slide number one, probably what you're witnessing right now is a case scenario which shows a 60 years old male who is presented to ENT OPD with hoarseness of voice and pain in the throat. So automatically, once we go into the details, the patient is of old age. He's 60 years of age, and he's a laborer by occupation. And what we analyze is that the hoarseness of voice, the change in voice, has been there for the last 6 months. Apart from hoarseness of voice, he also has some history of productive cough, which has been lasting with the symptoms of hoarseness as well. And now, accidentally, the patient has also developed dysphagia, a complaint of dysphagia in which he's unable to take in solids. So there's dysphagia for solids, but he's able to take in liquids. That is, the liquids are taken in, but the solids cannot be swallowed. If we go on to the history of presenting illness, now we are discussing a patient who's 60 years of his age. He has hoarseness of voice. So probably 6 months back, he was absolutely fine. Then all of a sudden, he developed some change in voice. That change in voice, that roughness in voice was progressive and it kept on changing. And once it kept on changing, automatically there came a time that there was a permanent change in voice, and that this is how the patient got worried. So let me just share a video of that picture so that you analyze what we call hoarseness. Hoarseness is a voice which is not clear voice. So you can see this voice of a patient. I'm going to play the video and you will be able to analyze the voice of this patient. So this is what a hoarse voice actually looks like, a muffled voice which is not clear. So this is an indicator there's something wrong with vocal cords underneath. And automatically that was the reason the patient ended up in the hospital, because now he had these symptoms of progressive dysphagia along with it. All of a sudden he started developing severe cough, and this cough was accompanied with sputum, and the sputum was bloodstained many a times. The symptom that brought the patient to the OPD was actually dysphagia. So the moment the patient developed dysphagia, it was difficult for him to take in solids. And semi-solids were comfortably taken in, but with a little resistance. So this worried the patient, and automatically he ended up in hospital. And we decided to admit the patient and then just to investigate what is actually causing all these problems. So going on to the history, once we analyzed the history of the patient, we got an idea that the appetite was all normal, but there was a history of weight loss. The patient shared that his weight was being reduced. Sleep pattern was all fine. There was apparently nothing wrong with the systemic examination, but the past history of the patient showed that he was hypertensive. Apart from that, no comorbid factors accompanying the present illness. There was nothing in particular important related to the present scenario about any past surgical history related to the signs and symptoms that the patient was carrying at now at the present condition. But yes, what was important was he was a chronic smoker. He kept on smoking for decades and decades, and automatically the the intake of cigarettes was around about 5 to 6 cigarettes a day. So change in voice, hoarseness of voice, with a history of chronic smoking, highlighted that there was something wrong in what we call the voice box or the larynx. Furthermore, the family history, once we are analyzing any person or we are screening him on the basis of malignancies, you always have to have a good family history. So once we analyzed the family history, there was nothing in particular which could add up in our diagnosis over here. As per the requisite, the protocol was followed, the patient was admitted, and a general physical examination of the patient was carried out. A well-oriented old age guy sitting comfortably on bed with vitals absolutely normal. The ear nose examination was all good. The oral cavity was fine. But what we analyzed on indirect laryngoscopy, that is examination of the larynx, there was an exophatic growth filling up the supraglottic area, and the left cord was fixed along with the growth present on the left vocal cord. So this was something that we highlighted in the examination, and maybe this was the beginning of what we call moving towards a prognosis, that we were actually seeing a patient of CA larynx. The ideally indirect laryngoscopy is of a very good opinion that gives you an idea about the hypopharynx, the larynx, the postcricoid area, the subglottic area at times, the supraglottic areas, but nothing better than a 70-degree telescopy. So once with the advent of the new medicine, it's always visible once you think there's a lesion of the cords. So just to analyze the lesion very comfortably, you always have these telescopes, and they're all easily available in all the operation theaters and in the OPDs in Rama Iqbal Medical College. So once the patient was, we found a fungating growth on the left vocal cord, we performed a 70-degree telescopy of the patient. And surprisingly, there was a left exophatic growth involving the left vocal cord. Now, once you analyze the growth on a telescope, you always have to enumerate the dimensions of the growth as well. You would actually highlight where is the growth starting from, where is it ending, what is the texture of the growth, are there ulcers on the growth, is it bleeding. So all of this would actually give you a very good idea about what you're actually seeing. So an exophatic growth which extends from the anterior commissure and goes supraglottically. Surprisingly, the airway was still intact. The patient did not have any difficulty in speaking, but because of this growth, automatically the left vocal cord was fixed. Now, fixation of the cord is because of three factors over here. Probably the tumor as itself might have invaded the muscles. It might be because of the local spread that the movement of the cord was affected, and it might be because of any involvement of the nerves, specifically the recurrent laryngeal nerve on that side, which would have caused damage to that side of the vocal cord. So the piriform sinuses were all clear, and automatically a 70-degree telescopy. Let me show you the video as well. This is what we saw on the telescope. So you can see an epiglottis. Let me stop it over here. So this is what we call a laryngeal inlet. So automatically what we see over here, let me highlight with the browser over here. This anterior portion is called the epiglottis. This is the inlet for the airway, and automatically these structures over here are the aryepiglottic folds. You have these tiny bead-like structures at the back, which are called the arachnoids. So this would be the right vocal cord, and this would be the left vocal cord. So what we see over here, the anatomical contours on the right and the left are approximately not the same. There's something lying on the left vocal cord, and automatically this is the growth. This is not a good finding, and automatically the growth looks like more of an exophatic fungating mass filling up entire supraglottic. So this is the only chunk that is actually breathing from. So apparently once the chunk is there, the patient was comfortable breathing. But what we analyzed over here, that this cord was automatically fixed as well. So you're going to concentrate on the movement on the cords now. Once I play the video again, you would be able to see the movement on the right is absolutely fine, but the movement on the left is restricted. So yes, the right is moving and the left is absolutely fixed. So this is what we call a laryngeal inlet, and these are the piriform sinuses. So automatically, why did he has dysphagia? The piriform sinuses though are clear, but what you see over here is the fungating growth going up to the anterior commissure and the arytenoid area at the back. So this junction, the interarytenoid area, is actually the area from where the cricopharyngeal junction opens up and you go into the esophagus. So automatically, because of this humongous mass swelling up the post-cricoid area, the patient might have had developed the dysphagia for solids, but automatically the mass is not big enough and the liquid might flow inside. So an indirect laryngoscopy gave us an idea that there was a mass in the left vocal cord that need to be screened now. The systemic examination did not have any major factor on the diagnosis, though it was all comfortable. The cardiovascular, the respiratory systems were all fine. The next phase was examining what we could do in this patient. So as once you investigate a patient, automatically the next plan was obviously getting a direct laryngoscopy and biopsy of the lesion. We have to rule out what kind of lesion. If we are even 100% sure this is malignancy, you need a histopathology to actually diagnose your case and move ahead. So what we did was we carried out all the baseline investigations to give general anesthesia, the coagulation profile, and everything was done. And after the basic baseline and the ECG, because he's above 60 years of age, we also carried on a CT scan just to see the extent. Now, once you perform a telescopy, you have a view of the lesion, but you don't know the extension, how deep it is penetrating into the muscles. Has this lesion gone in through the cricoid cartilage, and is it moving out of the larynx or it isn't? So what you need to analyze to see the extension of a growth is always a radiological investigation. And that in our case was actually a CT scan that we carried out. So a CT scan was carried out. These sections over here are actually the axial sections. Now, once you slice anyone from top to bottom, these are the sections that you reveal. So automatically, these are the piriform sinuses over here. This is the epiglottis. And once we come on to the other slide, yes. So once you look at a scan over here, automatically the left side is all filling up and automatically there's a lesion on the left vocal cord, which is more appreciable probably in this film over here. So the left vocal cord is all fixed and automatically we can see a lesion filling up the left vocal cord area, just to see if there's a metastatic lesion going on to the lungs as well. The CT was carried on from the skull base up to the diaphragm. Because you always have to analyze a tumor on the basis of Tnm staining. You have to go for the extension, you have to look for the associated lymph nodes, you have to see the distant metastasis, and a report was segregated. The biopsy was done, and the biopsy revealed an infiltrative, moderately differentiating squamous cell carcinoma. We all know that the glottic or the larynx, as we call it, is divided into three segments. There's a supraglottic part, which is above the vocal cords. Then there's a part below the vocal cords, which is called as subglottic. And automatically, then there's a glottic part. So the frequency of involvement of the glottic part is maximum. Mostly it is the glottic part from where the cancers usually rise. The frequency is around about 60%. Once we say the supraglottic, automatically the frequency is around about 40%. And very rarely it involves the subglottic part. So a plan was decided to remove because the cancer was into T3 and T4. Remember, once you stage a tumor, either it is T1 and T2 or it is T3 and T4. So T1 and T2, we usually go for a more conservative approach. It would be vertical laryngectomy, it would be a radiotherapy, it would be something which is conservative. But once you see a T3 and T4 lesion, you go for a very aggressive approach. And probably what we did was we went for a total laryngectomy. This is just a specimen showing that the diseased larynx was actually out. So what we saw in the picture before was actually the telescopy, and this is the specimen in total. This is what the entire larynx is all about. This is the epiglottis. These are the aryepiglottic folds. This is the right. This is the left. We can see a humiliating mass over the left vocal cord, and automatically it has infiltrated the mucosa over here as well. These are the arytenoids at the back. You have the hyoid bone on the top, and automatically at the base you have the cricoid cartilage. So the larynx as itself, the whole specimen was actually taken out. And this is again a view. This is the hyoid bone. This is the epiglottis on the top. This is the arytenoids at the back coming onto the lower portion. This is the mass. This is the tumor which goes. So if we have the vocal cords, we are able to see the vocal cords over here. So this portion of the mass is actually the malignant lesion which was present on the inside the larynx on the left supraglottic and left vocal cord. So the next thing was analyzing the extent of tumor. The tumor was segregated and it was sent for histopathology. The good thing about the tumor was it did not invade the thyroid cartilage. So thyroid cartilage is a part of larynx, and the moment the tumor approaches the anterior commissure, automatically it can move into the thyroid cartilage. So the moment it goes into the thyroid cartilage, the tumor is extralaryngeal. So the prognosis of the disease specifically comes down once you look if the thyroid cartilage is involved. So any tumor of the larynx that has actually invaded the thyroid cartilage means that it has gone out of the domains of the larynx, and now you're looking at a distant metastasis, and this is how it's done. So the specimen was sent in toto to the histopathologist, and these slides would actually show you the specimen histopathology which was carried out. It shows that the invasion of this differentiated modality, differentiated keratinizing squamous cell carcinoma was always there, and automatically this is how we manage the things. Now, what was important? The Tnm stenting. Once you look at a tumor, the biopsy is proven, and uh, the patient, the laryngectomy is performed. Now, you can't just send the patient away like that. You always have to give him a treatment plan. You've removed the larynx, that means he's unable to speak. You've created a new pharynx, that means now he would find it difficult to swallow. So automatically the patient has to be taken care of. You have to see for the relapse of the disease, you might see for the recurrence of the disease, and you have to plan out what has to be done. So after total laryngectomy, as decided earlier with the surgical oncology team, it was decided that the patient would be subjected to the radiotherapy as well, because the neck, the nodes which were adjacent to the larynx were spared in this case as they were not involved. So only the laryngectomy was performed, and this is how we ended up in our case. So the course is automatically 3-point strategy: patient strategy, the surgeon strategy, and the post-op management. You always have to counsel the patient how things are going to be managed. You have to see your own expertise, the environment that you're working in, with all the infrastructure that you have. You have the facility of radiotherapy. What if you do a laryngectomy and the radiotherapy data is after a year? Would that be comfortable for the patient? No. So automatically your consideration of the patient has to be catered, and automatically that is how you manage all these case scenarios. So advanced one, we look at any of the laryngeal cancers, we know automatically the prognosis of survival. Once we say a survival in laryngeal cancers, we are looking at a 5-year survival. So the prognosis is around about 70-80%. That means all of those patients who undergo laryngectomy for a tumor would survive the next 5 years. If they are not given a treatment and the surgery is not performed, automatically the prognosis might decline and the patient won't be able to survive for the next 5 years. So once you have a good enough survival rate, so laryngectomy is a good advantage. The disadvantage is, yes, once you take out the larynx, the voice is gone. So the more concept of organ preservation comes over here. So you always have to advise the patient. There are artificial means by which he can speak, but the actual sound box is missing, and the patient would be devoid of the normal speech. You have to give him an option of using prosthesis used to develop speech in the later slides, but automatically the rehab is very important. Once the organ is removed, now the rehab of speech has to be done in 3 pattern. Either the patient can use a pen and a paper to write, or automatically is guided to swallow the esophagus, the air inside through esophagus, then release it out into the pharynx, and then try to conversate using that air. Number two, you have these electronic devices. a device which is a vibrator, which is placed in somewhere, which is placed in the lower part of the neck. And once it vibrates, it moves down the muscles in the hypopharynx, and automatically with the movements of this muscles, the sound is generated, which is projected out through the uh, oral cavity, and automatically a sound is then automatically generated. So yes, once a patient is going through the episodes of carcinomas, emotional, psychological, physiotherapy is obviously taken care of. Just to give you an highlight on the OT table, now he is a patient who's been intubated, and automatically the thyroid cartilage and the cricoid. So this marks the larynx. This is the larynx. Now the other two lines, let me indicate with the browser, this over here and this over here. These two lines are actually the medial ends of the sternocleidomastoid. Incision is actually given from one border of the sternocleidomastoid up to the other border of the sternocleidomastoid. And this incision is usually 2 finger breadths below the cricoid. So you have to elevate a flap right from here up to the lower part of the mandible, and automatically this is the suprasternal notch. The clavicle, the medial ends of the clavicle has to be visible as well. So automatically they have to be taken care of in the same segment. Coming to the lower slide now, once the flap is elevated, this is what you see. The flaps are elevated from the top, the flaps are elevated at the bottom and from the top. So this is the mandible over here. You can see the lower part of the mandible and the medial end of the clavicle. So once you elevate the incision is given in the skin and so the subcutaneous tissue and up to the platysma. Once we go under the platysma, the anterior jugular veins are actually spared and they are taken up in the flap. The next thing that you visualize are these strap muscles. These are the infra-hyoid strap muscles. They have to be segregated and cut down. This is what we exactly did in the next slide. And the moment you segregate the infrahyoid muscles, you visualize a thyroid. So the thyroid is ideally retracted on the right or the left side. If a total thyroidectomy has to be performed, the thyroid is dissected. What lies medially to the thyroid are these branches, the internal jugular vein and so the carotid sheet and the internal jugular vein is separated from the medial end of the sternocleidomastoid and from the larynx, and automatically once the larynx is mobilized, the thyroid cartilage, if has to be removed, are taken out, otherwise they are spared. Now you be given once the larynx is actually visible, you would hold out the larynx through the epiglottis and start removing the larynx. Now, what is important over here that just behind the larynx you have the cricopharynx and the esophagus. So you always have to make sure a proper mucosal area is there to reconstruct the esophagus or the pharynx. You can't let this area of mucosa go away with the tumor. If the tumor has invaded this area of the pharynx, automatically it is an inoperable tumor. But once you see that there's enough mucosa to reconstruct the pharynx and a new pharynx or a new pharynx has to be generated, then we decide to remove the tumor. So once the tumor was removed, automatically this area of the pharynx was actually uh, spared and automatically it was reconstructed again. So this is just a slide again showing the lower part. So the esophagus, as we can see, once the larynx is separated away, automatically what we analyze over here is the esophagus and the opening. So now this is the open area of the pharynx, and this is called a neopharynx. Now this neopharynx has to be restretched because earlier you had a postcricoid area over here, which was taking part in the formation of the neopharynx of the pharynx. But now you have to create a new neopharynx, and this is actually the lower end as the trachea. The trachea is is taken out of the skin through a stoma, and automatically it is stitched with the skin over here. So new tracheotome, a new opening for the trachea is actually created, and the rest of the skin is actually closed. So this is the specimen that was taken out, and automatically this was the stoma that was left for the patient to breathe. Now there's no larynx. This is the only passage for the inlet and outlet of the airway for the lower air tract, and this is the passage that the patient is actually going to breathe from. The upper part Yes, you have created a neopharynx, you have placed an LNG tube, there are drains placed, just to make sure, okay, there's no post-op collection. So this is a case scenario that we discussed, a patient that we usually come with, most of the patients that we come across in outdoors with T3 or T4 lesions have to be treated in the same condition. You have to go for a total laryngectomy, either with neck dissections or without line dissections. Okay, so coming on to the introduction of cancers of larynx. What we see over here is, as I told you, that the laryngeal cancers are automatically the malignant tumors of the sound box. Most common region of the head and neck is the larynx, and most common over here are the squamous cell carcinomas. The incidence is quite more in the males. It's 4:1. The reason is because of smoking, nicotine intake, alcohol intake. Automatically, the men are far more affected. So they have a very synergistic effect. Anyone who has a history of taking in alcohol, who has a history of taking in smoke, nicotine, they develop tumors, and the frequency of alcohol with smoke is far more as compared to alcohol or the nicotine alone itself. The peak incidence is usually above the fifth or the sixth decade, and automatically in Pakistan, this is increasing too much. Now, apart from the alcohol, as I told you, this synergistic effect, anyone who's smoking, it's a very risk factor. But once he's smoking and he's an alcoholic, automatically the risk increases 11 times. Apart from these, namely irritants, you always have chemical carcinogens. Anyone who's working in factories, the paint factories, the petroleum factories, the asbestos, so automatically they themselves are being exposed to all of these chemicals, and such irritants might cause any of the damage in the mucosa of the larynx and would dispose them to these conditions of laryngeal carcinoma. Just to give you a brief anatomy of the larynx, larynx is a passage from which the air enters from the upper part of the airway into the lower trachea. It's just a passage, but the important function of the larynx is phonation. The voice is generated in this larynx. So it is, the other name of larynx would be the sound box. And as I mentioned, it is a combination of cartilages and muscles. So there are six cartilages over here. You have three paired and three unpaired. The paired cartilages are smaller in size. The unpaired cartilages are bigger in size. You have epiglottis, you have a thyroid cartilage, and then you have a cricoid cartilage. So all of these cartilages have a posterior end which is open, except for the cricoid cartilage. It has a signet appearance, just like a ring, and it covers the entire larynx. But apart from these, you have the paired cartilages in the form of cricoid, the arytenoids, and this is the histopathology. It's actually made up of elastic cartilages, keratin plugs as well. Uh, as I mentioned, the larynx, we segregate anatomically it into three parts. The portion above the cords, the supraglottic, the portion involving the clots, the minutest portion, the glottic, and then the portion of the larynx below the glottic or the vocal cords is called the subglottic. So automatically the glottic cancers, they usually are 70 to 75%. That means this is the narrowest area of the larynx. So once we look at the anatomical structure of the voice box of the larynx, it is more of a dumbbell shape. It has a broader supraglottic part, it has a broader subglottic part, but the glottic area, because of the vocal cords, is very narrow. So it is exposed to most of the allergens, and automatically it is more exposed to trauma as well. That is the reason the glottic carcinomas, they arise mainly in the glottic region, and the frequency is around about 70 to 75. Now, what is important over here? We see a section. These are the vocal cords. This segment over here is the anterior commissure, and this would be the posterior commissure at the back. The posterior commissure are lined by the two bead-like structures, which we call the arytenoids. And from the arytenoids, you go posterior into the postcricoid area, which is the cricopharyngeal area, and automatically into the esophagus. So if the tumor arises somewhere at the anterior commissure, with the browser, I'm showing you the anterior area. This is the anterior commissure. From here, if the tumor goes into the thyroid cartilage, where would it come? it would come into the skin outside of the neck. But if the tumor arises somewhere over here at the posterior side of the larynx, automatically where would the tumor go? The tumor would actually go into the posterior part. So coming to the other part, supraglottic, this portion of the larynx is actually the area above the vocal cords, and it is comprised of 3 to 4 different things. It has a false vocal cords, an area epiglottic folds, and epiglottis on the top. So this is what a normal vocal cord would look like. White bands, these rings are the trachea that you see underneath. So subglottic is the minutest portion. So supraglottic is a large area. You have the piriform sinuses on the either side. These are the area epiglottic folds, the arytenoids, and automatically the anterior commissure and the interarytenoid area. So the percentage of tumors arising in the supraglottic area is around about 40. It's 70 in the glottic area, and it's around about 35 to 40 in the supraglottic area. So that means major chunk comes from the glottic, then the supraglottic, and probably come into the subglottic. It's very rare. It's even less than 1 to 2%. You would hardly see any of the cancers arising in the subglottic, but any cancer in the subglottic is something very dangerous because it would go down into the trachea, and once it goes into the trachea, automatically you are looking at distant metastasis. The ideal symptoms and signs related to the site of the tumor, we would be discussing it in the next slides. So number one, you look at cancer in the glottic area. So what does the glottic do? It creates speech, noise, and sound. So automatically what would happen if there's a chunk onto the vocal cords? The first thing that would happen would be number one, change in voice. So automatically the patient would not have a very clean voice, and automatically any change in the periodicity of the voice is called hoarseness. You have an aperiodic sound which is rough, muffled, as we showed in the previous slides as well. So you call it that the patient has a hoarse voice. Number two, automatically, if the chunk is too much, automatically the cords, they get involved and they would get fixed. The moment they get fixed, they go into a paramedian position. So the rima glottis, which is the aperture of the glottic area, gets disturbed. It would get narrowed, and because of the turbulent flow of the air, the patient would not be comfortable breathing. Once he's not comfortable breathing, what is going to happen? Stridor. He would end up with dyspnea. He would have problem in breathing, and automatically if the lesion is too big, he would start coughing. Once he starts coughing, there would be blood coming out, and all of these symptoms would start arising. Number two, as I mentioned, if it goes posteriorly, what you are involving is the arytenoids and the interarytenoid area, and from there the postcricoid area starts, which is the area of the origination of the cricopharynx. So once it goes posteriorly, it involves the esophagus, and yes, symptoms of dysphagia would arise, as we mentioned the patient had in our case. So a supraglottic cancer might have a lump in the in the neck, and automatically a supraglottic would have all those symptoms which the glottic would actually have. Subglottic is something very dangerous, though it's very rare, less than 1%, but yes, you're looking at a very narrow lumen, and as soon as the tumor arises over there, the first symptom is not hoarseness, it would always be stridor. So the patient would actually come to you with episodes of stridor. He's actually gasping, he's unable to breathe, and automatically that is what brings him up to the hospitals and the OPDs. So change of voice, yes, and automatically the major symptom is always stridor. So as we mentioned, once we look at the tumors, you always have to segregate your tumors on the basis of Tnm. T stands for the size of the tumor, N stands for the nodal metastasis, and M stands for the metastasis as itself. So automatically T, the tumor that we look at in larynx probably is divided into 4 segregations. Either it is T1, T2, T3, and T4. The size of the tumor is related in centimeters. If you're looking at a tumor less than 2, you label it as T1. If it's 2 to 4 centimeter, it's T2. 4 to 6 centimeters, it's T3, and automatically anything greater than that would be T4. So this is how we segregate. We are able to visualize the we were going to stage the tumor. So TNM is important because the staging of the tumor is very important. And the moment the staging occurs, automatically you are able to course your treatment plan. If you are looking at a T1 and a T2 lesion, automatically it is a conservative approach. You might think of going ahead with radiotherapy or a conservative treatment. But if you're looking at a T3 and a T4 lesion, you're looking at a very aggressive disease. Now, the steps taken have to be aggressive at the same time. So a love segregation, what is important in laryngeal cancers is the Tnm classification. The T classification differs a little for the glottic, it differs a little for the supraglottic, and it differs a little for the subglottic. So once you look at T staging of the tumors in the glottic area, as I mentioned, T1 limited to the cords, T1A, B, one cords, two cords. But what is important over here is T3. Once the tumor is so big that it has actually fixed the cord, you're looking at a T3 lesion. And T4 is moving from the glottic area in some other domain of the larynx. So this is the staging. There's an entity which is called carcinoma in situ. Now, is this something to worry about? We come across a patient who has hoarseness, you do a biopsy, and the histopathologist labels you that he has carcinoma in situ. Now, this is actually a good prognosis for the patient. He has come to you at a very early stage before the tumor has actually as itself shown up. So carcinoma in situ has a very good prognosis, and automatically that means it has to be taken and treated in the same way as you treat any of the glottic, the subglottic, or the supraglottic cancers. So carcinoma in situ means that there is a high potential of these cells which are malignant, they are present in the larynx, and there's a good enough possibility they would develop into cancers and they're going to spread. So before anything happens, you can go with the removal of these cells. So this is the mode of spread. If you're looking at a larynx over here, where would the tumor actually go? The tumor might go into the supraglottic part. The tumor might go into the subglottic part over here. It might go anteriorly and void the thyroid glands, come out through the neck. It might go posteriorly and invade the cricopharyngeal junction, the esophagus, and it might go into the backbone, the spines as well. So that is the reason the cervical spines are very important in this case. Most of the tumors, if they have a distance or a local metastatic spread, they might go into the cervical spine as well. So how would you diagnose? Remember, diagnosis of anything is a tree-based agenda. Number one, it's always the patient who's going to carry up a symptom. Number two, it's your examination. And number three, it's the help of the radiological or the histopathological examinations that you do. So patient with his history, a good examination by you as a surgeon. And number three, automatically any help from the radiologist or a histopathologist on the basis of FNA or biopsy would help you diagnose a laryngeal cancer. So it cannot be taken away. Any change in voice, any difficulty in breathing has to be evaluated. Change in voice for a period of more than 6 weeks. 6 weeks means 1.5 months. So anyone who comes to you with a persistent hoarseness has to be evaluated. You can't let him go away like that. Ki ji, awaaz badal gayi hai. There's no problem with that. It has to be screened, and automatically you have to take a good care of that uh, change in voice. Techniques, as I mentioned, yes, you have the orthodox method was always an indirect laryngoscopy. We used to have these mirrors. You used to have these indirect laryngoscopic mirrors. You used to have the head mirrors. You have to use the bullseye lamp. You have these headlights now. So automatically, by visualizing the larynx, uh, the normal anatomy of the larynx is different, and automatically, if you are able to visualize any pathological feature in the larynx, that has to be screened. With the advent, we come across the fiber optic laryngoscopies, which are more comfortable to use. Now, they would actually give you a better view of the larynx as well. Apart from that, automatically, the patient visualization is better. The patient is more comfortable. You are able to see the hidden areas of the larynx as well. We can have a very good view of the interior commissure. You would have a very good view of the uh, posterior part or the subglottic part. So automatically, which are actually the hidden areas in indirect laryngoscopy, you are able to visualize those areas. Examination, as I said, the third point of the strategy is getting the help of a radiologist. Now, we do, once we are looking at a tumor, we have a two-dimensional view. We don't know if it has gone into the bone. We don't know if the thyroid cartilage is involved. We don't know what is the depth of the tumor. So you have to have a proper CT scan. And all of these tumors, remember, you always get a scan, which is with contrast to see the bony involvement as well. Number two, it would give you a good enough idea of the lymph nodes, because anything, any pathology, any malignancy in the neck has a greater incidence of moving out through lymph nodes as well. So once you're looking at lymph node involvement, automatically the treatment plan might differ. So we can't just rule it out by simple flexible laryngoscopy or indirect laryngoscopy. We need to have a CT scan, an MRI that is going to give us a good idea about the tumor, the size of the tumor, the depth of the tumor, the invasion of the cartilages, the bone, and automatically the lymph nodes associated with it. Now, how would you do that? Number one is always a biopsy. You can't go ahead with total laryngectomy immediately. First of all, you have to get a histopathology. And the best way to do that is doing it under vision, under direct laryngoscopy. Once the patient is completely relaxed, you give an anesthesia. The muscles are all relaxed and automatically go into the larynx. You are able to visualize the cords over here. These are the cords. This is the left vocal cord over here. These are the area epiglottic folds on the top. These are the arytenoids at the back. This is the subglottic and the tracheal portion. So automatically an indirect laryngoscopy would give you a good idea. Just to wind things up, how would the treatment plan be? As I mentioned, there are multiple treatment strategies of managing it. Step one, you're looking at a cancer, you stage the cancer. T1, T2, T3, T4. Now you know you're looking at the stage one and the stage two. You think, yeah, the patient can be managed in a very conservative way. You're looking at a cancer which is stage 3 and 4, you have to go for a very radical approach. So the options and the treatment follows your staging. So number one, radiotherapy. Yes, radiotherapy can be done in patients T1 and T2 lesions, stage 1 and 2. But yes, it can be done in patients, those who are palliative. What if you come across a T4 patient who cannot undergo laryngectomy, who's unfit for anesthesia, he has comorbid diabetic and multiple other comorbid conditions. So automatically you have to cut down the extent of the disease, and that can be done with radiotherapy. Now, this radiotherapy is just to make things comfortable. It is not a total radiotherapy or curative radiotherapy, as we call it, in which we plan to eradicate the disease. This radiotherapy is done just to make the symptoms a little bit comfortable for the patient, and this is called palliation. Number two, yes, surgery. Now, surgery is a two-point strategy. If you think you're looking at a T3, T4 lesion, automatically you would go for a total laryngectomy. But I mentioned, if you're looking at a T2 lesion, and automatically the cords can be spared, the tumor it is involving just the posterior part of the larynx. What can be done is you can go with the hemilaryngectomy. Then there's a combined therapy in which the patient that we dealt with is we did a surgical laryngectomy for the patient, and then we subjected the patient for radiotherapy just to make sure that the lymph nodes which are left back into the neck, they're subjected to radiotherapy, and there's no incidence of tumor arising or distant metastasis arising from any of the lymph nodes. Number three, with the latest advancement, we have this facility called laser. Laser, though it is quite expensive, the diode laser, the carbon dioxide laser, what they do, is actually they would uh, they would help to reduce the size of the tumor, and this is how we manage the cases. So probably this winds up our entire the latest modalities of the radiotherapy. This is how it looks like. So this is what we usually do. We subject the patient to the radiotherapy, and there are different ways of doing radiotherapy. Is organ preservation significance. Now, once you're removing the voice box, automatically the patient has to be sympathized in the same way. You're going to tell me he's not going to talk for a while, and automatically once the voice box is removed, he's unable to speak. So what I would do is I would tell him that maybe there are other ways by which he can speak. So automatically we have these electrolarynxes and other things which can be taken care of. The rehab has to be done on a two-point strategy. Once the tracheotome is created, automatically the upper airway is all gone. You lose humidification. You leave the nose, the paranasal sinuses. So automatically the air that is taken into the trachea is dry. It is unfiltered. It has different temperatures, so it might be irritable to the lower airway. What you do is you need proper humidification. The voice is not there, so automatically there are three-point strategies: pen and paper. Number two, these electronic devices, which you call the electrolarynx. and automatically, which is less costly, is always the esophageal speech. You would make the patient, tell him how to speak using his esophagus air. So he's managed. He's told to swallow the air. The moment he swallows the air, he's told to expel this air through the esophagus into the mouth. And the moment it comes to the mouth, then with the movements of the tongue, a muffled speech is actually created. So this is the two strategy. You swallow the air through the tracheotome, then make it out come through the oral cavity, and automatically the electrolarynx. This is a more technical support, though it is costly. It's a vibrator actually placed somewhere in the hypopharynx. The moment you place it in the hypopharynx, the neck muscles, the muscles of the hypopharynx, the tongue, they start vibrating. With the movement, a sound is generated. That sound generated is actually converted into proper speech with the movements of the tongue and the lips. So automatically, electrolarynx is a very good option in making the patient speak automatically. So, so this is how an esophageal speech would look like. You see, this patient doesn't have a larynx, but then he is able to speak. Just listen to his voice. Okay. So automatically, this is how it works. And this is the prosthesis that we would actually go ahead with. So the take-home message for today's lecture, though this was one-way direct input, and we would always advise that there's a two-way input, that we get a feedback from the students as well. But then again, the take-home message for this is, in case of hoarseness, you have to investigate the patient. Hoarseness that persists more than 3 weeks or 4 weeks, say a month, has to be investigated. You can't let it go away like that. And the main irritants of laryngeal cancers is smoking, it is alcohol. So avoid that, live a healthy life, and probably things are pretty much comfortable. And hopefully, this covers up your malignancies of the larynx. And hopefully, we would be seeing you in the next lecture. Thank you very much.